So a very good morning, and I'm really thankful for incorporating me into this symposia, and my great friend Dr. Vavika, Dr. Somil, Dr. Alkesh. So I'll be talking on optimizing patient outcomes with presbyopia correcting IOLs. I'll try to put it as a debate because I just lost my slides, so whatever I could retrieve. So we all, as cataract and refractive surgeons, we all know that presbyopia correcting IOLs have become a great gambit in our armamentarium. And what we are looking at is a patient having 20/20 vision day one. So very important is the right selection. So right selection means the IOL selection as well as the patient selection. So for me, I spend more chair time when I talk to my patient and assess the requirement of the patient. So I think hearing from the patient and looking to his demand is what is very, very important when you're dealing with such hypercritical patients. Collecting preoperative data, and I use all my diagnostics whenever I'm treating these kind of premium patients. And for me, every patient is premium because at the end of the day, what I'm looking at is day one 20/20, whether I do a phaco or a refractive surgery in my practice. So K readings is very, very important. I think we all have aborted manual keratometers, but I think I have one of the keratometers lying, and in situations where I cannot, I go and sit and use this manual keratometer. Automated, yes, we all have an access, and I think all our IOL masters and all our optical biometers have an incorporated K readings inside it. So topography is again very important because it gives me two major things. I get the axis where I need to actually locate my torics and the degree of astigmatism. I think these are the two areas where I will second on this topographer. I'll master have an access to both 500 and 700, and I think all the major formulas are incorporated. And most of the patients now that we see are post-refractive or maybe short eyes, long eyes, and I think that's the gray area where we actually need to optimize our settings, and we really need to look into multi-formula approach, and with our experience I think we can address and again translate to 20/20. OCT, yes, all my patients are there are subtle lesions in the macula which can at times be missed. So all these premium patients are addressed to OCT, and the macula is always assessed. And eye tracing, yes, we do all the angle alpha, angle kappa, and aberrations calculations. And this is one great tool which I would always subject for my toric patients preoperatively and postoperatively to assess the right location of the lenses. Meibomian analysis, yes, it's a great, and we have this lippy view. So any patient where we have any kind of dry eye, we would first subject these patients to the lippy flow, and then subsequently take these patients for phaco-refractive surgery. So I think this is one gray area which we actually need to see, because poor ocular surface is what is a great hindrance to 20/20 day one vision. You actually, after all this, now sit back and discuss with the patient. So my practice has boiled down basically to monofocals. Monofocals, I would always go for advanced monofocal and advanced monofocal torics. And when I go for presbyopia correcting IOLs, I think it is just limited to basically EDOFs. And EDOFs is basically to those patients who either have a bad macula, glaucomatous patients, or hypercritical patients, or patients demanding, and they are, night driving kind of stuff, abnormal size of pupils, and uveitic patients. I think these are great candidates for EDOF lenses. And the second subset would be those patients which desire a great distance near an intermediate, and these are those candidates for the trifocal lenses. And my personal choice, number one, has been the Ateliza, no financial interest. I think it's a great lens and it works very well. And most of these patients, I have hardly to find any patient cribbing for any photopic phenomena. And the second, I would a great fan of the Synergy from Johnson & Johnson. No financial interest. So, and then you need to actually put in alternative scenarios to the patient. So a quick work, what I do is follow this Dr. Holliday's corneal power decision tree. Patients are taken on a keratometer. If there is a standard deviation more than 0.2, assess for dry eye, treat the dry eye after 6 weeks, and then reassess, do a topography. If the patient's standard deviation is less than 0.2, check out the cylinders. If there is any toric, there's no toric, you can do any great formula on the 700, take these patients in the OR. If there is a toric, you need to assess, do do a topography, assess the cylinder and the degree of astigmatism, and then calculate out what is the exact power required for these torics. So now our practice has shifted almost to 70% of the torics, because we normally take these patients anything more than 0.75, we will take this on a toric platform, and less than 0.75, we'll take these patients on an LRI on our femto platform on the Catalyst. So quick preoperative considerations: patient should have a strong desire, the age, they should be, looking at multitasking, and pre-existing ocular pathologies have to be ruled out. Hypercritical patients, yes, you really actually need to sit back, talk to them, and it's better to have no for these kind of presbyopic correcting IOLs with these hypercritical patients, because these are those patients who would actually waste your chair time, come back again and again, and crib, and these would be those dissatisfied patients because they actually do not understand what they want to know. So occupational night drivers sometimes could be a no for these the presbyopic correcting IOLs. So as I said, sometimes low myopes, this is something debatable, but this could be one where we actually need to discuss, because all these years they have been without glasses for near work. And pupil, yes, sometimes for these decentered pupils, traumatic mydriasis, subluxated cataract. So I would always assess these patients full dilated on the slit lamp to assess any kind of zonular weakness or subluxations, because any kind of moderate to severe subluxation would be a big no for these trifocals or presbyopic correcting lenses. Any kind of surgical complications that we have during intraoperatively, I think we should not have any ego kind of stuff there, and we should always discuss on the patient with the patient on the table, and we should always have an alternative scenario. We've seen a lot of patients having those dislocated not on the axis, and then patients complaining of glare, vitreous in the anterior chamber. So I think this is a big no. If you have an open bag and the lens getting decentered, I think the ego should not come in front, and these should not be taken on these kind of IOL platforms. So high HOA, large angle kappa and alpha. So if you see here, we do eye tracy on all these patients. So anything angle alpha more than 0.5 would be a big no for these kind of lenses. So on the aberrometer front, so HOA more than 0.7, coma, trefoil, tetrafoil, anything more than 0.5, 0.4, 0.3, and any fifth order more than 0.2 would be a big no. We always do a quick dry eye workup. A quick word about these lenses available in the world market. So basically boils down into bifocals, EDOFs, and the trifocals, and each one of them have their own merits and demerits. But between the bifocal and the trifocal, we have almost shifted to almost trifocals because of two great reasons, and specifically with the Athlesia, the kind of light distribution that they have, 65% for distance and 35% for near. I think that gives a great distance, intermediate and near vision to all these patients. So the Athlesia Tri basically works on the LISA principle, where LISA is the light intensity distributed asymmetrically. So 65% distance light goes for the distance, 35% for the near, and the rest is for the intermediate. And it basically is pupillary independent, and the SMP technology is basically what it is, the surface, the lens surface. I'll just summarize. And the aberration correcting optics. This is the defocus curve that you get with the Athlesia tree, and great distance, a good intermediate, and a great near vision. And mind me, it works even in, none of the patients have complained of any loss of contrast in these patients, and photic phenomena I find is minimum in these patients. So a great presbyopic correcting IOL that we've been using, and thank you so very much.
Yeah, Dr. Sonu, it was that topic was very important topic you are discussing on. Just wanted to ask a personal question from you. Using some lenses, because you are not using anything for presbyopia reading.
Sorry?
You are not having any glasses for reading.
Me?
So, yeah. So
I'm still young. I'm younger than Somil.
Okay, one thing, just hold on. So I'm just starting that. So in case you get a presbyopia, which lens you will prefer for yourself?
So that is what I talk to my patient. The first thing, that if I had been in your case, because I drive maybe 5 miles in a day, I have a driver, and I spend most of the time in my clinic, in my chamber, in my house, and I love mobiles, I love iPads, and I love screen time, and I hate glasses. So I think the trifocal suits me the best to my personality, and I would still, if I have 1 in 100, if I have a photic phenomena, I'll still prefer to have it rather than to compromise using glasses. So I think with all these modern trifocal IOLs, be it the Athleisure from Zeiss, be it Synergy from J&J, they work.
I agree. These are very good lenses. And I agree with you. But the people,
I think the biggest thing
in case the people, the people who are driving, doing everything on their own, they don't have driver. So which lens you will like?
Still, I believe that those patients who are occasional drivers, city drivers, their driving is limited to
No, they are driving on their own.
So if they are those patients who love driving and they are highway kind of drivers, I would take these patients on an EDOF platform, and no proprietary interest. Vivity works very well in these patients.
Yeah, I agree with you.
So I'm a great fan for these lenses because this works very good distance, very good intermediate, and then you may just give
I tell you, once both eyes are operated, because I have done a lot of these AIOC IOLs. So once both eyes are operated, so there's not an issue of intervention. Even they can work for near also very well.
Correct.
So not like that they can't work for near. They don't have any issues. Only thing you have to very accurate with the biometry.
Yes.
And secondly, you should make sure they don't have any retinal or macular pathology.
Exactly.
Non-diabetic patients having likely to have diabetic retinopathy or early stage of diabetes, don't put any trifocals or AIOC lenses in those cases. And the most important advantage of AIOC, I'm telling you, is there is no loss of contrast sensitivity. Because with all trifocals, any matter, doesn't matter how good they are, you will have a loss of contrast sensitivity. AIOC will never have a contrast sensitivity. So in case I feel, maybe you feel that I feel AIOC lenses for the young people, otherwise they are the best lenses.
So I think you have very nicely summarized the gist of my thoughts.
I want combination. One eye trifocal and one eye.
No, that's not,
Nice,
because AIOC is basically monofocal lenses with the extended depth of vision. They are not multifocal. So you can't do that combination.
So in that case, the patient would come cribbing with the trifocal that they see the glare halos, because then the at the cortical level it doesn't get balanced. So these are not the ideal patients to be suited. I think Hoya recently launched their trifocals where you have geometric and geometric plus, where you can have a paired approach. If you at all you need a good near, I think they've shortly world is moving towards these kind of approaches. But EDOF with trifocal is strict no.
There is a button of swap displays on the top. Thank you.
Thank you, Sonu, for your excellent presentation.